Merci beaucoup. Thank you for having me back. I got stuck in the elevator. Every floor. And time was running.
It's about cure.
Yeah, it's about cure. It's a slow process. For some. Okay. Well, it's important to have an understanding what cure implies. Obviously, long-term follow-up is needed, probably 15 years of progression-free and complete response survival. It's important to remember that some patients actually revert back to an MGUS-like state and may have MRD positivity and yet live 20, 25 years. So this should not discourage one from not curing, not labeling these people as cure candidates. It's very important to have sustained follow-up with appropriate myeloma marker analysis, bone marrow examination, and importantly, imaging. There are secondary cures, that is, patients who may have had a relapse and then are treated effectively and have sustained decades complete remission. How should one approach curative therapy in myeloma? I trained in acute leukemia with my former mentor, Jay Freireich, who only recently retired. And it's important in this context to employ all available treatments up front, including regimens that recently have found to be effective in relapse, a la total therapy that St. Jude Children's Hospital has developed. I think the total therapy approach is justified by the presence of intraclonal and, as we now know, spatial heterogeneity in myeloma. These are the total therapy schemata based and built around tandem transplant with melphalan 200 milligram per meter squared, the introduction of consolidation therapy, and then proteasome inhibitor therapy for maintenance. Long-term follow-up on total therapy 1 shows here that among 231 patients initially enrolled, 30 remain alive, 19 progression-free. And of the 79 patients who entered CR, 10 remain in continuous unmaintained complete remission. In total therapy 2, the only randomized trial that I initiated with the addition or not of thalidomide, you can see here that it took 5 years or so for the curves to separate. So when the paper was published in the New England Journal, there was a progression-free survival advantage for the experimental arm, but the overall survival was identical, and the curves didn't split until 5 years after starting treatment. This is important to remember for many of the studies that we have seen during this meeting. Progression-free survival by arm, you can see the superiority when in patients who received the experimental arm with thalidomide. Complete remission duration, you can see plateaus are not emerging until 10 to 15 years from initiation of therapy, in this case from onset of CR. In total therapy 3A, we added the proteasome inhibitor Velcade for induction and following 2 autotransplants with melphalan, we introduced VTD-PACE as consolidation therapy and then VTD maintenance. And those are the results. Complete remission duration from onset of first CR is shown here. And you can see at 10 years, approximately 50% of patients are and remain in complete remission. Dr. Crowley at the time was our statistician who headed the myeloma committee in the Southwest Oncology Group, and you have seen this picture probably, and he modeled, according to our outcome cure estimates. They are shown in the dotted lines, and the experimental data are shown in the solid lines. When one then tries to estimate cure fractions from either PFS or CRD curves, you can see in case of CRD in the upper panel, approximately 50% of those 189 patients entering CR are estimated to be cured. John Shaughnessy had developed the GAP70 model similar to the HOVON model, and you can see there are profound differences for low-risk disease on your left and high-risk disease on your right. As in high-risk and high-grade lymphomas, the cut point from which one can judge whether cure or not has been observed is earlier than in low-risk disease, constituting 85% of patients. Here's an example of a cure that happened in a patient who had been entered on total therapy 1, I believe in 1993. She achieved complete remission and came off treatment in 1994 and then suffered a relapse. At the time we looked at Enbrel, which was ineffective, and she was entered on a dose-escalating Revlimid phase 1/2 protocol in 2005, or in 2003 rather, entered complete remission and has not relapsed to this date. I saw her recently in New York. The importance of imaging cannot be overemphasized. Niels Weinhold has published this nice paper on spatial heterogeneity that some of the speakers at this meeting have addressed. And it's important, really, in a curative program to perform not only random but fine needle aspiration examinations of these lesions. It's important to perform serial imaging studies, including MRI and PET scan. MRD negativity in a random marrow is insufficient when one has cure as an objective. In my view, myeloma has joined the club, the Sky Club for Delta or others, of curable cancers. High-risk myeloma can also be cured, but in a much smaller fraction. That cure plateau is apparent at an earlier point, maybe at 5 years, whereas in low risk, that's the majority of 85% of the patients. One needs 10 to 15 years of continued follow-up and beyond. We are seeing patients who followed me from Arkansas to Mount Sinai who have been out 25 and more years. It's important also to remember that not all complete remissions are created equally. That is, when one obtains complete remission and even MRD negativity with some novel agents without transplants, they are unlikely to be durable. We therefore recommend not to abandon transplant therapy prematurely. I think this came out at this meeting, and it's important to test novel agent approaches in very high-risk disease, because then one can determine in due time, that is within 5 years, whether plateaus are emerging and whether this approach is worthy of pursuing. Where do we go from here? We are performing still in New York gene expression profiling, as it gives us, in my view, the best estimate of very high-risk disease based on the 70-gene model. We perform mutational analyses. We also do the liquid biopsies now. For low-risk disease, I think one should continue the total therapy 3 approach, but only in patients who really qualify for having symptomatic or real myeloma. I tend to observe patients for several months before starting, unless they have hypercalcemia or urgent needs to be treated. We have begun to incorporate daratumumab in the maintenance approach together with proteasome inhibitor and immunomodulatory agents. For high-risk disease, it's important to collect enough stem cells. We are applying daratumumab before and after transplant, and also have incorporated daratumumab in maintenance therapy. What to do about high-risk relapse? I think our approach with metronomic, that is stretched out 28-day therapy, employing VTD and low doses of cisplatin, doxorubicin, vincristine, plus daratumumab weekly, has shown very promising results. I think we're the first to employ trametinib in a patient who had liver disease due to myeloma, who had received intrahepatic artery infusion, chemotherapy, embolization, and the likes, and was given trametinib and entered complete remission within 3 to 4 weeks. That lasted about 10 months. There are some patients who exhibit the BRAF V600E mutation, and the combination of dabrafenib and trametinib, as in melanoma, works in myeloma, and many of the earlier patients, when myeloma was not well appreciated, thought they had melanoma. Importantly, and this is based on data by Philippe Moreau, venetoclax is amazingly active, especially when dosed high at 800 milligram, combined with a proteasome inhibitor and nalfinavir that the group in Basel had found to be effective in enhancing proteasome inhibitor activity. And we have found this approach to also work in patients without 11-14 translocation. We have begun to use proteasome inhibitors, both ipilimumab and nivolumab, and we agree that it's especially effective when the tumor mutational burden is high. And I'd like to thank the organizers here, the patients who have trusted us. I remember starting Total Therapy 1 in Arkansas in '89 and proposed tandem transplants and heavy induction therapy consolidation. And they really didn't know anything from Adam, and they just went ahead with my recommendation. So this was not so bad. And important were the wonderful healthcare teams that I experienced at Anderson, Arkansas, and now at Mount Sinai. And I thank you for your attention. And sorry for being late.
Thank you, Bart, for this very good and outstanding talk. In fact, you are the only one able to show some very long follow-up up to 20, 25 years in your experience, and that's very important to see, as you mentioned, the very long follow-up of clinical trials. But Bart, these patients were mostly young patients eligible for stem cell transplantation.
Well,
in your practice, in your routine practice.
No, let me answer the question first. The median age there was 63, and the age limit was 75. They got melphalan 140 over age 65.
Okay. So in your routine practice, for those patients that are not eligible for stem cell transplantation above the age of 75, for example, what are you proposing? What is your optimal approach for these elderly patients?
Well, first of all, autologous transplants shouldn't be called transplants. So one can give them lower doses of melphalan and boost them. So if insurance companies agreed, I would give them 70 per meter or whatever is appropriate. So I wouldn't rule out the use of melphalan or an alkylator like melphalan for these patients, but with stem cell support.
Could you say some words on CAR-T strategies?
On which strategies?
On CAR-T cells for myeloma.
Which cells?
The CAR-T.
CAR-Ts.
Oh, CAR-T. I'm sorry. I guess I didn't want to hear this. Well, I think we all have been impressed with the short-term efficacy. A patient from Colorado followed me to Mount Sinai and actually received CAR-T cells. He had not entered complete remission on any previous therapies, including transplants. He entered complete remission very quickly. That lasted 8 months. Then he relapsed, got another CAR-T cell application, and progressed right through it. So another patient whom I inherited when I moved to Mount Sinai had CAR-T cells at the Dana-Farber. First time 8 months, then also progressed, and she's in near complete remission on high-dose venetoclax, nelfinavir, and bortezomib. So it's certainly active, but I think as we have heard in the session on immunotherapy, there are ways to improve.
Hervé, please.
Yeah, but so you showed that here.
Oh, monsieur.
You showed that in all your total therapies, real high-risk patients, the median overall survival is still 2 years. And so for high-risk relapse, you moved to metronomic therapy.
Yes.
Why are you still proposing high dose for frontline high-risk patients and not move directly to this?
I think daratumumab has changed the landscape. So I had the fortune to take care of a college professor, a physics professor from Texas. He came to us for the first time when I moved to Mount Sinai. He had developed extramedullary disease in muscles. It's often a preferred site, skin lymph nodes. And within 3 weeks of starting single-agent daratumumab, he was in complete remission and is maintained now 3 years later on monthly daratumumab without the addition of an immunomodulatory agent. So I'm really impressed with daratumumab, or with this approach. Because
in your, you said, remember some times ago, you said that high dose maybe is not good for this patient because you will add more mutation, more. Well,
that's you know, as one ages, time passes faster. So I'm really embracing the immunotherapy approach, and this agent, the CD38-directed antibody, through its multiple aspects of mechanisms, I think can change this.
Yes, Laurent, you have one question?
Mr. Barlogie, Laurent Garderet from Paris, France. Thank you very much for your outstanding commitment and results in myeloma. I've been following patients for more than 10 years in CR, and they still relapse. So maybe like in CML, I would call it more operational cure than strictly speaking cure.
An occasional relapse should not argue against curability. We see relapses late in childhood ALL as well, and in Hodgkin disease. And people don't argue against the principal curability of these diseases. An occasional relapse may be due to a totally new clone. I think those patients should be studied in great detail to see whether it's the same disease or a different one. But the occasional late relapse should not be held against the principle of curability.
Bart, last question. Now that we have very effective agents in combination with daratumumab, stem cell transplantation, in standard risk patients, we are going to see some patients alive without any recurrence of the disease during 5, 10, 15 years. And the results of the clinical trials will be very, very long. In fact, we are running the Cassiope study, VTD plus or minus daratumumab. So I think that we have to wait 5, 6, 7 years to reach the median PFS. To reach the median PFS. So are you
much longer? If you care about, if you want to be a myeloma doctor, yes, and really want to make a difference, you have to stick with it. I think 15, 20 years, otherwise you cannot talk about anything.
So that's why my question was, are you using in your routine practice MRD assessment systematically to predict the outcome of your patient? Are you using MRD also to alter therapy, to change of treatment, for example, during the maintenance phase?
I guess I'm a little bit underwhelmed by MRD. We do it routinely, but I have many patients, long-term patients, with a documented unmaintained complete remission by other criteria 20 years later who have MRD positivity. So my thinking is that we may be dealing with an MGUS precursor condition that has reemerged, and would be wonderful if one could sort this out.
I think that you should publish a new paper. I know that you have 600 papers already, but this kind of information are very, very important.
The problem that I'm in, since I left Arkansas, I don't have access to the data. That's my one and only. It's a major handicap, anyhow. If you help me in getting access, I will. You can be first and senior author, both.
Thank you, Bart.